Hey there, hello, good evening. Welcome back to I Care for Your Brain with Dr. Sullivan. That's me, board certified neuropsychologist. I am so happy to be back with you again. It's been about 2 weeks since we've been together for a live lecture. And what we are going to talk about tonight is probably the thing I care about most in my commitment to the brain health community, and that is the long-term care and support and love of people who have dementia, significant cognitive impairment. And it has been a very frustrating experience for me to want to contribute to better care for these folks, because I'll admit that at times I have felt powerless. I've been unsure at times of how myself as one person can make any meaningful contributions. So I have been very, very happy in my own community to discover a resource that I think is really the beginning of the answer, is really the first step in piecing together a patchwork quilt of support and services to help these very important members of our society, and that is palliative care. And you might not have heard of it, so I wanted to take this time tonight to really help you understand how it might be able to help you or a loved one. And what I hope is that after you listen and you understand, that you will help me spread this message, because it is, in America anyway, a Medicare-based resource, often an insurance-based resource that just goes unused. And so I want you to know exactly what it is. So I first learned about palliative care from a wonderful, really in-depth, I had always known about it a little, but a wonderful nurse practitioner in my community. And she really helped me understand what their services were, and that one of the barriers of palliative care is that it often gets lumped in with its sister service, which is hospice. And so one of the things that's important is to talk about the distinction and talk about specifically what palliative care can offer folks. And, before we had this service, I know many of you have had the experience of going to a medical doctor, maybe a neurologist, with someone with dementia, and you either get told, I'll see you in 6 months or a year, which can feel like an eternity. You can be told, there's nothing I can do for them anymore. And you're just kind of left there all on your own as a family member, as a caregiver. And it's really not right. It's really an ethical failure of our society. So if we just take a step back and define some of these terms, if some of you are new, dementia is a broad umbrella term that has cognitive symptoms, physical symptoms, functional symptoms, meaning people lose some independence because they can't do their activities of daily living in the same way, and often so-called behavior symptoms. It's kind of a syndrome. Dementia is a great umbrella term, but what that means is underneath the umbrella, there's many different types of brain diseases that cause the state of dementia. Things like Alzheimer's, vascular dementia, Lewy body dementia. There's about 150 actually, with about 5 to 7 being the most common, typical, what I see as a neuropsychologist. While everyone who has dementia is different coming into their diagnosis, everyone's dementia is also a little bit different. But one common theme that is true for many people is that there can be a long period of decline, a long period of what we would call deterioration. So about 40% of people's time spent in dementia is in the more moderate to severe stages, and that can be about 40% of the time. So many people living with this type of brain health challenge, including, we're talking about dementia, have complex care needs, and a lot of this falls on families and caregivers, specifically spouses. So we really needed to have some kind of specialized medical care that really speaks to the ongoing care needs of these folks, improving quality of life, not just for the person, but also for the caregiver. So palliative care for anyone is not well understood, like I said, but especially for folks with dementia. So let's talk about some of those distinctions between hospice and palliative care. So hospice is really there for the final stages, okay? And palliative care can offer comfort and support years and years before somebody is expected to pass away. The criteria for both programs does vary a little bit according to the specific facility or people providing it, of course, but in general for hospice, you have to be about 6 months near to the end of the person's life. You typically can't walk without assistance, dress without assistance, very hard, if not impossible, to bathe, incontinence, language, being able to communicate needs. So one of the the criteria that they use is approximately half a dozen or fewer intelligible or different words. So as you can see in dementia, we know some of that stuff can go on for months, if not years, and so technically you really wouldn't qualify for hospice. Palliative care, like I said, can happen at any time, and they have some very specific services. So they are really there to provide services in the home, but they will help transfer the person to the appropriate skilled nursing facility if it looks like they can't stay at home anymore. They can help to navigate a very complex medical system, and they can really help you make informed care decisions for yourself down the road. One of their biggest desires is that quality of life. So to make sure symptoms are properly managed, to make sure that we're not extending suffering, to give people and their families a sense of control, how to live the very best life possible for everyone affected by the dementia. So these services are provided by specialized medical providers, volunteers. There are certified palliative care nurse practitioners, palliative care certified physicians, social workers, chaplains. People have to go through some pretty specific training to be able to offer these specialized services. I'm always interested in how these services began. So this one goes back to the UK, and it was really started after an outcry from the public that they didn't have enough resources for cancer patients. But over time, what they noticed is there's plenty of other conditions that need to be acknowledged as reducing quality of life. So for palliative care, the diagnosis really doesn't matter. It's just if somebody has a life-limiting disease and they would benefit from the prevention and the relief of suffering really by any means necessary. So they focus on physical pain, anxiety, agitation, trying to really make sure they capture all these elements of someone's functioning. Palliative care for folks with dementia developed kind of separately and really pretty recently, but I definitely will give props to you folks in the UK and Australia. You guys are always a step ahead in dementia care, and I really admire that. Dementia folks are eligible for palliative care at any point from diagnosis to last day of life. The needs of the person will change. So in a minute, I'm going to tell you about something they offer called goals of care that can happen as early as the initial diagnosis. Over time, of course, they're focused on making sure the person isn't undertreated for things like pain and agitation, but also that they're not snowed on medication. If someone doesn't understand dementia, this is what a lot of us fear, would be going into a home and being over-medicated, right? Being stuck in the corner. So we want people who understand that you don't do that to human beings, right? You don't do that to people who need you and are really dependent on you for their care. Dementia is a medical condition that requires increasing amounts of medical care. At a certain point, a caregiver really cannot be expected to do it. It's not just a matter of the intensity of the physical and the mental commitments. It's really a medical problem that has to be treated as such. So one of the things that makes advancing dementia so difficult and so painful for those of us who are experiencing it as a bystander is that people have more and more trouble expressing themselves, expressing their needs, telling us what is wrong. Even things like, I'm hungry, I need to pee, I'm thirsty, I'm cold, I'm bored, I'm lonely. So these needs get expressed in other ways, right? Typically through behaviors. This is the so-called behavior symptoms of dementia, which these actions can be things like wandering, hitting people, cursing, however you say that, looking at their face, and you can see that something is wrong, but they just can't tell you. So instead of ignoring these things or considering them to be, the person's acting out, these things in a dementia-specific palliative care program are interpreted appropriately and with a human instinct to comfort and to take away the problem. So this is where these folks will use medication if needed, but they're not going to rely on it. They are going to take more of an environmental intervention first. And I think that is really what we need. There is dementia-capable palliative care. That's how we call it in the US. And what that really means is that there are practices and protocols within that palliative care program that are specific to people with dementia. So for example, with pain medication, they might not just say one in the morning, one at night. They might follow the person during the day, taking note of their individual behaviors, and they might realize that, it's really not something that we should wait 10 hours for until she looks like she's in pain now. Let's just give it, as it appears that she needs it. They're going to pay attention to things like the way people with dementia want to eat, need to eat. They are not understanding maybe a utensil anymore. So there's going to be finger foods, right? Folks with dementia tend to gravitate towards sweets because some of the taste buds go away at the advancing stages of dementia, and folks can only taste sweet, right? Their brain also needs a lot of glucose to manage the symptoms of dementia. Being flexible just about things like when people get up, get out of bed, when they want to eat, what their routines are. It's not just a tolerance, it's an acceptance. It's an embracing that these people are, you're either on two sides of the caregiving coin in life, they say, right? You either need it or you give it. And each one of us could be in each other's shoes very quickly. So really trying to pay attention to what they need and individualizing care is what they're all about. There's really three things that they do very well. This is pain, thirst and hunger, so eating and drinking, and agitation. Pain is the most common symptom across palliative care, no matter what you're there for. Maybe we think like 50% of people will have significant pain. Folks with dementia, though, it actually goes up even more because not only do you have all the stuff that accompanies older age, like, trouble with your dentures, arthritis, urinary tract infections, constipation, these things that affect older people. Now you've got difficulty experiencing it and expressing when you need help. So now we've got kind of a threefold problem, right? Eating and drinking is really a problem in folks with advanced dementia for multiple reasons. So having dementia, you sometimes forget to do your oral hygiene routine. You can have difficulty swallowing. About 42% of people, they think, in the last couple weeks of life with dementia forget how to swallow, okay? The most frequent cause of death in people with Alzheimer's disease is aspiration pneumonia. From choking on food, it goes down the wrong pipe and starts to build up bacteria. So people with dementia also take medications that might lead them to have dry mouth. So instead of just sticking a plate with food in front of them, they are going to be sensitive to what is on the plate, how palatable it is. And there's also places that implement evidence-based research. So making sure they know that the color of the plate is going to be optimal. Red, for example, as we know from the famous Boston University studies, that folks with dementia have contrast sensitivity issues. And if something is of a similar background to the foreground, they have difficulty perceiving it. So if you are serving milk in a white cup, forget it. What they say in their study, Tracy Dunn and colleagues, is, mashed potatoes on a white plate. You're not going to get the person to eat because they can't visually perceive it. So we've got sensitivity when designing these types of protocols. Agitation, this is the most common and persistent behavior symptom. Up to 70% of folks with advancing dementia have agitation, and when it's there, it's lower quality of life for that person and the caregiver. When they try to look under the surface of what is causing that symptom, pain, boredom, and isolation tend to be the three things. So instead of maybe being first to treat the pain as pain, they're going to take the time to go underneath and try to figure out how can we treat the baseline issue that's really causing it. So they're going to be more apt to first change the environment, interact with the humans, try to be behavior detectives to figure out exactly what it is. This takes trained staff. This takes the right staff in the right job, okay? If you know a home health aide or a certified nursing assistant and they are good at their job and they love it and they take care of these special people, please, please, please love on them and tell them how good of a job they are doing. They typically spend the most time with folks in these situations and they get paid the least. And that is something that really, really needs to change. So remember, I was telling you before that I've been using palliative care in my practice with my patients more and more. And what we're doing is sending them to a palliative care clinic. And the focus is something called goals of care. And this is a big thing in advanced care planning. And what this basically means is that while you are in a good cognitive state, you're going to make decisions for your future self when you may have some impairment that impacts your ability to provide proper consent. And you're going to decide early with a supportive professional, do you want a feeding tube? At what point would you want your family to maybe put you in a facility? There's really personal, sensitive questions. And in my experience, they can be extremely cathartic for patients and their loved one, maybe even more so their loved one, to tell you the truth. It's a topic that is kind of the elephant in the room, and until we know what that person's wishes are, I think it's really hard to provide the optimal care that I know so many of you want to provide. It feels like it would cause anxiety to have those conversations, but I think it can actually do the opposite and make everybody feel like they have a plan. And my God, in the brain health community, if folks could just feel like they had an informed plan, I don't think as many of you would listen to me because you'd be getting it from your doctor. So who is going to get you to palliative care? Okay, it's probably going to be you, a caregiver of a person. Your doctor might not necessarily understand dementia. They might not have experience with folks with dementia. They might not know how hard it is. They might be hesitant because we still know, unfortunately, that doctors have a hard time bringing up death and dying. It's really important that you take all the support and especially all the insurance-based resources that you can get in this process. And I'm telling you, it's very underused. So ask for it specifically. Ask for a palliative care referral. The ideal time to get these services may be while a person is in the hospital, if that comes to be, especially if you find yourself being in there more than a few times in a year. It really might be time, and they can probably transition you into the program as easily as possible. So let's prove to the system that when they provide a service for our people with advanced dementia, that we are going to use it, okay? Please, let's not miss this opportunity to reinforce the medical system that yes, we need these services and we are going to access them. We just need to know about them, okay? So please do me a favor and share this lecture on any type of social media platform you have, especially if it relates to the care of people with dementia. We really need to do a better job of communicating what's going on and how we can help people. Okay, thank you so much. We have our next Brain School on November 11th at 6 p.m. Eastern Standard Time. This is lecture number 8 of 9. We only have one more after that. And this one is focused on a topic that I know is very much on your mind, which is sleep. Sleep is probably something we've learned about the most in the last 5 years in brain health science, and so many of you struggle with it. You cannot have a healthy, optimally functioning brain without good quality sleep. So we're going to talk about what gets in the way and how to do your very best to get that sleep that I know you want so much. Take care. You can go on the website to sign up for that, icareforyourbrain.com, or there'll be a link in the comments below. Thank you guys so much, and I'll see you soon. Bye-bye.